Welcome to Perspectives in Peds, or PIP for short, your go-to podcast for insights into paediatric practice. From clinical approaches and emerging research to the everyday wins and challenges, we bring you OT perspectives that inform, inspire, and spark conversation.
Hello.
Hello. Hi, Dan.
I am joined by Caitlyn and Caitlyn today, and I am in the host seat, which I'm very excited about.
Woohoo.
We are here to discuss the newest evidence around sensory processing off the back of your latest presentation on evidence-informed practice in the area of sensory processing.
Yeah.
Which is it's a tricky topic.
Well, it's quite interesting. And I think one of the weirdest things about it, like sensory processing, so synonymous with OT. But then once you go through all of the evidence, it's actually very interesting how most of the articles are like, yeah, so we got this information, seems all right, but need more evidence. And that just continues on and on and on.
And no one ever does more rigorous studies.
It's literally every single study, the, implications for practice. It's like the last point is like, the suggestion is more research into this area.
Isn't it interesting though, because 9 years ago, I did my project placement on developing a sensory space.
You didn't do well enough because there's not enough evidence.
Well, it was a horrible, horrible project placement because there wasn't any evidence. And my understanding of evidence-based practice back then was purely research-based evidence. So it was very difficult. So I'm pleased to say that there are newer meta-analysis and more rigorous studies that have been done, which is great. What were some of the findings that you guys sort of found when looking through the most recent evidence?
Yeah. We tried to use like a good combination of we looked at some of the practice guidelines that were available. We used the Autism CRC national guidelines as well. And then there's been some more recent systematic reviews and that kind of thing. And one of those of which came out late 2025 was
excellent.
Off the top of my head, Pillar et al. And that looked at the most recent evidence from 2014 to 2025.
I really feel like you guys did your homework to remember these things because I feel like it's to impress me.
Well,
you're
the
our
host.
resident evidence girly. Systematic review.
Before we came on, we were joking that Danni's not really hosting. It's actually an assessment of how well we research. So we'll just drop buzzwords in. Level 1, research.
Strong evidence.
RCT.
P values.
Yes.
Rigorous.
Statistically significant.
Yes, etc. But Pillar 1.
That one was really great and looked at sensory-based interventions, which did not include because then we were looking at the difference between those kinds of interventions and then sensory integration and AIRS.
So can you give me an example of what a sensory-based intervention is?
Yes. So they talk about, in that particular study, 3 different subtypes, I suppose. So they talk about parent and caregiver education, or parent and caregiver is kind of the end of that sentence.
Yes.
Environmental modification and a sensory technique where they're talking about something that is actually being almost applied to.
Done to a child or a person. Like a wheelbarrows, would that be considered?
I don't know.
Like brushing?
Oh, yes. Yeah. But they didn't actually look at that in that study.
Okay.
So they looked at weighted vests or the use of a treadmill.
Was Qigong looked at in?
Not in that one
Not
specifically, no. But that did come up when we were looking at the guidelines because that came up as one of the…
I think that was one of the only studies that actually has strong evidence around it, which is fascinating. It's Qigong massage.
Yeah. So we tried to pick that apart and look at, I guess, when we're looking at how do we apply it to our practice, supporting within the webinar, we were really supporting clinicians to know this is what's available from an evidence and research perspective, but that's one key component of evidence-based practice.
So when we talk about evidence-based practice, it actually is that Venn diagram that I actually have in front of me so that I do not mess it up. We've got 4 circles that overlap because it is really common to think that evidence-based practice is just about the research evidence. So what you've got is, in order to deliver evidence-based practice, there's an overlap of clinical expertise, research evidence, information from your practice context, and then also client values and circumstances, which is like surrounded by your clinical reasoning.
And this is the Venn diagram that we have developed, but the information is taken from Hoffman, Bennett and Delmar, who have actually written their newest version of the book was done in 2024, and it is actually a textbook that is purely on evidence-based practice in allied health. So it's actually, if that interests you, it's definitely worth a look, but because it is so valuable, particularly, and sensory processing, I think, is where this really shines.
Definitely.
Yeah.
Well, that's why we especially feel that way after looking into all of that recent research, because it is really clear that the research evidence is not everything. And if it were everything, we're doing a lot of weird stuff.
Yeah.
Because
We are not an evidence-based.
which is crazy given
Profession.
how much we have to do with sensory processing with OTs, and other allied health clinicians listening also obviously have things to do with sensory processing because we're sensory beings, so the people we support.
Yep.
Also, like everyone has sensory needs.
Yeah.
They're just different. So one of the big things that we did find in the research that we loved was the differentiation between sensory processing differences and sensory processing challenges. So just because something is a difference does not make it a challenge. So for example, let's say that you have a lower auditory threshold than expected, but you live with two parents, you've got no siblings, you're homeschooled and you live rurally. Let's say there's not much noise, happening around. So technically that could be a sensory processing difference, but it's not causing you a challenge. And this was one of the really helpful things we got from the research, and we hope can really anchor a lot of therapists, because if, families come to you and they're sort of like, no, he's really sensitive to sound, we need to make him less sensitive to sound. Well, we do know that we can't really change a person's thresholds anyway, but I think being anchored to the fact there's such a big difference between sensory processing difference and sensory processing challenge, and they do not automatically equal one another.
Yeah,
absolutely.
And so we really went down the path of when to intervene in terms of, is there a functional impact?
How validating, because that is something that we really pride ourselves on differentiating.
Yeah, it's really lucky when we deep dive and it actually lines up with how we practice.
Yeah.
Yikes.
But I think it's important for a lot of, particularly new grads or people that are newer to the
Absolutely.
space of supporting sensory needs, because I know if I was a new grad sitting in a seat and I had a caregiver say, they're really sensitive to noise and we want to change that, I would have said, okay.
Yeah, absolutely.
For sure. You're like,
If
I'm
that's what you want.
family-centered.
Yeah.
I think I'll do that.
Yeah.
So that's where that blend crosses over to, with your scope, and because part of that evidence-based practice Venn diagram is the client values and circumstances. So we want to be responsive to
That's
that,
it.
but it obviously needs to be balanced with the evidence as well and your clinical expertise.
Yeah. Another huge part of the evidence was your ability, or that intervention should be really individualized, and you need to look at the evidence but look at the person that you're working with. And so also emphasize the importance of your confidence in evaluating a child's sensory preferences and processing needs, so that it's not a cookie cutter approach, and that you're really working to support that child's sensory challenges versus trying to take it more from a generic intervention. Oh, well, this one has strong evidence, so we'll just use this one.
And I do wonder, and my sort of pondering on the lack of rigorous evidence around sensory processing is due to that individuality of sensory needs.
individualised.
Yes, we can't clone 100 of one person with
it.
the exact same sensory processing preferences. So it's really hard to measure.
It's
So it
also
actually is
quite subjective.
Yes.
Because it is it's either subjective from the person observing or it's subjective from the person experiencing. So there is no objective measure as such.
Yeah.
Yes, and Katie, actually we were talking about some of the things we were really surprised about by the research before we came in, which has reminded me your point that you were.
None of the research outcomes are child experience.
No one asked the kids.
No one asked them.
Somebody asked the children.
Someone think of the children. So no one has
so hard.
asked the actual kid if they think the intervention was
Which
supportive.
plays, so they look at a lot of I guess, formal outcome measures. And yes, that they might do like parental stress levels as an outcome, but there's not much around the child outcome. And that then plays into some of the other things that were surprising as well, because when we're not asking the kids about other things that perhaps has lower levels of evidence, like environmental modifications, but the kids are the ones that are genuinely going to be able to tell us if that was helpful, if we did something to modify the environment. It makes sense why there's not great evidence around those kinds of things.
So our Venn diagram, which has our client values and circumstances, apparently the client does not include the child.
Yeah, just forget that in this instance.
Oh, my word.
But yeah, because that really makes it very clear then too when you read some of these studies. And obviously a lot of the time with research evidence, we're still very medical model.
Yeah.
We're slowly coming out with some more ND affirming research, but boy, it's a slow process. So it's also important to note, and this is with any research evidence that you read, but being really aware of the outcome measure that they're using that says it was successful.
Yes.
So in one of the studies, I'm pretty definite it was an RCT, but we read it through a systematic review, is that the success of the intervention was reducing autistic mannerisms.
Yes, I did see that.
Which is obviously not what we are after. So you really want to be careful with what with where the research has been deemed as good. Sorry, the intervention has been deemed as a good intervention. And that's what Katie was mentioning before too, that very surprisingly, environmental modifications came out as like
insufficient.
And
the one study they
used is environmental modifications in a dental office.
Oh my gosh, I have read that study.
Of course you have. This is bedtime reading for Danni. How have you? What do you mean you've read that? When?
Don't act surprised.
I'm pretty sure it was when I was doing some research around sensory processing, because it is the only one
that came up in the guidelines.
I believe it was when I was doing a school-based presentation. So it was around work, and I was actually
sounds like a hobby. Anyway.
Nothing wrong with that.
I think that that one was super fascinating because, I mean, I'm a bit of an outlier for the dentist, but no amount of environmental modifications are also going to make me hate the dentist less. Like the dentist can be notoriously quite tricky for kids and some adults. And it's not anyway, whatever. It's just an interesting study to do just there, but also how interesting that we don't have more with that, because this is where we really lean on a lot to do with the client values and circumstances and our clinical expertise. You cannot tell me that if you're like very light sensitive, that dimming the lights won't help.
Yeah.
You can't tell me that's not help. And with our clinical expertise of just chatting with our kids with sensory processing differences and challenges, we have a lot of anecdotal evidence around those sorts of things working.
Is it interesting as well? Because when you think about that and then the lack of conversation had with the child themselves, you are then putting a label on what their behavior is suggesting. So if you see a child, for example, you dim the lights and they start flapping and you're like, that's actually exacerbated their sensory need. It's like, actually, maybe they're like flapping because they're feeling really comfortable.
Yeah.
And some of the outcome measures too, compliance.
Yes. Yeah. This is
Which is nothing to do with actually, I mean, obviously there can have something to do with it, but that is not directly related to the regulation and sensory regulation that those interventions are actually trying to measure.
So then how do we take the evidence into goal setting, knowing what we know about the evidence?
Yeah. So Cowie and I kind of discussed that we want to be able to take that evidence and create meaningful goals. And one of the main things that we landed on was that and the evidence backs this, is that your goals need to be, an intervention should be participation focused and not looking at the remediation of symptoms. So really shifting away from, goals surrounding being less sensitive to noise or to tolerate a hug or whatever it might be, to what does participation and function look like?
So taking OT back to occupation.
Yeah.
Love
revolutionary.
Love it.
So that including that it also should be ND affirming, that it should be client and family focused and led as well. There were some really important things that we then, if we feel confident being able to set goals around that and evaluate based on that, that we should be able to then take that through our intervention as well and not just lean on just clinical research for intervention selection, I suppose.
And based on the fact that there is or has been historically, there's a lot more coming out, but has been historically a limited amount of evidence, it is so important to be able to lean into that information from practice context, lean into that client values and circumstances, because then we need to let that impact what our intervention looks like. And like my mind is a little bit blown, to be honest, about the environmental modification, because that is such a core, I mean, as OTs as well, environment is such a huge thing that we consider, but I feel like that's always the undercurrent in the OT space has always been that that's the thing that has evidence is, and I guess it's anecdotal at the end of the day. It's not published. So it is anecdotal that we see that our kids participate better in their occupations when visual clutter is minimized or when they wear headphones or whatever it might be. So how do we apply the evidence in its entirety, in that whole Venn diagram, into our planning and intervention?
Yeah. Well, we at KidLink, I mean, we're family-centred here as it is, and we hold great value in parent and caregiver education and coaching and training, which is nice because that is one of the interventions that does have strong evidence around it. And so, but there is so much to be said around that, particularly if you're looking at the like sensory-based interventions and the sensory techniques and that kind of thing. What they are really leaning on is that parents and caregivers need to feel confident and competent around applying this in a child's natural environment as well. So if they don't understand what sensory processing is, what their child's sensory preferences are, and why we're doing what we're doing, they can't then carry that over into their natural environment.
NDIS, that if we move all therapy into the school environment,
it won't work.
It will not be evidence-based, even though part of evidence-based practice is working in the natural environment. We are eliminating a key central character in that, which is the parents and caregivers.
So well, they won't fund censor anyway, so don't worry.
Oh, yes, sorry. I forgot about that.
Danni, you've gone 8 steps too far.
So we kind of first step of our intervention really should be building the caregiver's understanding of what these goals even mean and what sensory processing is, and what like here at KidLink we use Winnie Dunn's model kind of as our base a lot. So we explain what neurological thresholds are and regulation patterns and styles are and what that then looks like for their child. So that is like a really core component of intervention for us and our recommendation, I suppose, based on the evidence.
Yeah, because you also want to explain the evidence around intervention, which I know is sort of what we're speaking about now, but a key component is then letting the parent know what it is, because it actually is not evidence-based to go in and have goals around changing that child's sensory thresholds.
Yes.
The goals are really around the participation focus, and then you can help to change their lens away from, well, my child can't participate because of their sensory processing differences, to more like that's very close, but they're experiencing mismatches for participation due to the sensory processing challenges. But the answer to that is not remediating the sensory processing side. It's remediating the mismatch.
Yes.
So once you also can explain effective intervention, you're much better set up, and that you reduce those quite awkward misunderstandings that you may have where the family, have a goal around potentially, no, they need to tolerate a hug, and you're like, oh, I don't like that. That feels really off. And you can actually switch it to the participation focus and feel really confident that you are making an evidence-based recommendation with that.
Yeah. We also then look at, again, like if we are truly being child-led and family-led, and if we want the child's feedback around strategies that we're exploring, trialing and implementing, that we want to educate the child on
Is that
what
actually
this is.
in in any article?
Not that I came across.
Okay. So do it, please,
yes.
because we know that it works.
Yeah.
But we know that it works from information from practice context.
Yeah.
And if Danni says it works, it works.
But we have found that a child can, you know, from quite a young age, show some understanding of when we have this input in our environment or within our body, does it make you feel comfortable? Does it make you feel uncomfortable? And what kinds of strategies might we explore with that? But if we just do things to the child without them understanding why, there's a really big missing piece there. So here at KidLink, we educate both parents and caregivers and also kids around sensory processing and their preferences using like a buckets analogy. And we've found that kids really respond well to that in terms of understanding. I'm not going to go deeply into it, but that their buckets for each sense might be of different size depending on their neurological threshold, and that things fill the bucket and things empty the bucket out. And the aim is to find, how do we meet your bucket's level, basically.
I'd be interested as well. I'm not sure if you guys came across or read any articles around adults' perceptions, and we obviously are a pediatric practice, but when we think about Hoffman's model, the Venn diagram, that part of that clinical expertise piece is actually taking the evidence, but potentially if there is no published evidence from a specific population group, can we take published evidence from another population group, utilising our clinical expertise and say, actually, that probably applies to this population as well. So I'd be interested, did you read any articles around adults?
No.
Yeah, because that would be an interesting space as well if you are interested in doing your own research to our listeners in terms of, okay, if you want to look at individuals' the education they receive about their sensory processing, I'd look into the adult space and
That's a good point.
How have they felt in terms of receiving understanding about their own sensory processing. And then that is kind of that additional backing that we have in terms of, okay, let's apply that to our kids. We know anecdotally it works, but if we also want a bit of that published evidence, it's worth utilising that.
It'd be interesting to
too.
see how much is around on that. But we do know from the, providing neurodiversity affirming supports that we do know it is very evidence-based to listen to lived experience.
Absolutely. Exactly
so
right. Which
we
again
know
is using that clinical expertise lens.
Yes. So we know that is something we should be doing. And then we also know through the autism CRC guidelines, because there are recommendations in there around that individualising and involving the child.
Yeah.
Look at this beautiful EBP. Makes my heart so.
So something that we really put an emphasis on, if anyone that's listening has ever attended one of our webinars, it comes with a workbook that includes really practical and what did we call usable resources.
Usable. Yeah, I should have looked up a better word before getting on
that
here
we hope
as well.
people can use literally the next day, but something that we really wanted to include. User-friendly, yeah, I think that's what we also landed. Anyway, we wanted to include resources that had opportunity for the child to reflect and communicate, how particular strategies worked for them. And because, again, the evidence, that's kind of what was missing is when we trial a strategy, how do we know it actually works? So our resources and activities for therapy and that kind of thing really included a lot of that, active participation of the child in those processes of selecting and trialing strategies.
And I actually just had a thought to almost jump back to the start. Sorry, hopefully it doesn't throw us, but something really important that we sort of have known, but I scoured for more information to fully confirm it, is that sensory processing disorder is not a diagnosis.
Yep.
So I just want to be clear for that for all of us, because you may actually even find it written on GP or pediatrician letters. It is not a diagnosis.
And it's not a diagnosis in the DSM at all.
No.
So my understanding is even cross-country, it's not diagnosed. People who use the DSM for their diagnosis, so the
It's
US,
not in
for
there.
example. It's not in there. So when it is spoken about, that's not to say that people don't self-identify with having sensory processing challenges or
Yes.
sensory processing differences, but no, it's not a diagnosis.
And the only condition in the DSM-5 text revision where sensory processing differences are part of the actual diagnostic criteria is autism.
Yeah.
Not ADHD.
No, it is listed as I'm going to forget the exact wording, sorry, but basically like something like an associated feature for other diagnostic groups,
Yes.
but almost in a bit of a different way. Like, for example, it's in there for obsessive compulsive disorder, so OCD, but under sensory phenomena.
Yes.
In terms of potentially feeling sensory
And I
input.
imagine things like schizophrenia perhaps for like hallucinations or
Yes,
delusions
but
or
not
things like that, but
diagnostic
not
criteria.
Yes. So that'll be the other thing that, and we know as OTs, but I know we've got multiple clinicians listening who may be involved with diagnostic. We aren't on the we're not the diagnosing
primary
clinician.
diagnosing clinicians. Yes.
Diagnostician.
Diagnosticians, yes.
Sounds right. Usable. Diagnosticians. But we are not the diagnostician. I hope that word's right. But we can certainly be on the diagnosing team.
Absolutely.
But just know you are not looking for sensory processing disorder. And if you are on that diagnostic team, which we often are for an autism assessment and diagnosis, you may be providing that both formal and informal evaluation regarding adding to that diagnostic profile for the diagnosing clinician. But we aren't diagnosing, and I can confirm with no shadow of a doubt that at this current point in time, sensory processing disorder is not a diagnosis.
Yeah.
I think it's really important to make sure that we're feeding back to other people within the child's environment as well, like the teachers and the educators and things like that. And I guess that is the other question I have is the research that you guys looked into for the presentation. Was there much discussion around like school environment, for example? I know the dental environment was definitely explored, but school environment, because that's such a huge occupation for our children.
Yeah, there was some again, coming back to what Cowie was saying around behaviour and compliance and stuff around like trialling the use of tea stools for attention.
Is that like a wobble stool?
Yes.
Yes.
Yeah, sorry. So there was like some specific interventions
which is not found to be helpful for attention.
No.
Yeah, fascinating.
Which is based on the adult observations.
Yes. Because I was going to say, the kids that grab it here, when I say, do you need something other than this chair? And they then are able to attend to the task and say that helped, still evidence.
But how interesting, because when you think about it, it's probably an adult being like, well, then they just swung around on the chair the whole time. And
Well,
it's like, but did they answer your questions?
Yeah.
Because they swung around the chair on the whole time because that's what it was there for, but they answered your questions successfully.
Yeah.
So, fascinating.
Yes.
If
So
that is the
I think,
participation.
our key takeaway was like, look at the evidence, but that is one piece. And how do you actually
the published evidence.
Yes, and take that into your practice and really think about the child that you're working with and get their feedback and work with the important adults in their life to understand the functional impact or what is actually supporting their participation as well, which again, we often don't think about how someone's sensory preferences can actually be a strength and can support participation at times rather than just what's impacting. So that was probably one of our last kind of takeaways when we're talking about intervention as well, is how can we be strengths focused and use what works for them across their environments too.
Again, coming back to those really key characteristics of occupational therapy. And I think that that's probably really where our role in sensory processing, even though we didn't have the published evidence piece and we still don't arguably in pediatric practice, we didn't have the published evidence to really back that. It really came down to bread and butter OT. It came down to occupation. It came down to individual experience. It came down to environment. It comes down to those really core principles of OT. And I think that within our discussion today, and particularly within the presentation and the webinar that you guys recently did, that's what the discussion really encapsulates, I guess. And so if you are looking for more information and more resources, we do encourage you to
Yeah, it will be available in the coming weeks on our on-demand learning platform, KidLink Education. So we will at some stage be able to put that link in the show notes, and you will get access to the workbook and the resources and everything too if you do decide to do that. But otherwise, jump on your whatever you have access to in terms of search engines and have a look at some of the more recent evidence if you're interested, because it's very interesting.
If you are an OTA member, you do have access to the American, Canadian, British and Australian journals and PubMed.
Yes.
So definitely worth a look. Scrub up on those EBP skills that you may not have put to use since university. And we hope today's conversation has sparked some ideas and thoughts and conversations around your practice towards sensory processing and how you work on sensory processing with your client group. And we look forward to you joining us next time. Thanks so much, Caitlyn and Caitlyn.
I was going to say, thanks for having me. Thanks for hosting, Danni.
Oh, yes.
Thanks for having me.
Yeah.
We'll see you next time.
We will.
Bye.
Bye.